the involvement of law enforcement in the lives of individuals solely because they have a mental illness. And, this is an important policy consideration that should be ongoing. An adjacent issue to law enforcement involvement in the lives of individuals with serious mental illness is the barrier crimes issues, and you'll have some folks this morning who will talk to you probably in more detail about that. But we're very supportive of finding a way to ensure that somebody's criminal justice involvement does not unnecessarily keep them from employment options where they can actually use their experience to do well. We've taken a piecemeal approach over the years and saying, this crime you can screen for, this crime you can't, this is a showstopper, this one isn't. And I think, it might be a good idea at some point to take a comprehensive look at the actual policy regarding barrier crimes. I know that DBHDSO right now is engaged, their Office of Recovery, in doing some things to kind of streamline the screening process and some checklists for individuals who wish to gain employment so that they don't end up going all the way through, let's say, the peer recovery training and then discovering that they have a barrier crime in the background that's going to keep them from being employed. So I think, do those kinds of things first and then move towards looking at the whole concept of barrier crimes. Another important kind of policy decision that this body made that we were obviously very supportive of was adding intoxication as a reason for requesting a medical TDO. That's an area where, it was kind of a global understanding of the statute that was a little bit different in practice than it ended up being as opposed to the written language. And so clarifying that intoxication would be a reason to kick off and request a medical TDO, I think is a good thing because it speaks to a broader policy issue of how can we take the pressure off of our state hospitals by helping to think creatively about specific populations and over the interim individuals who are intoxicated as well as individuals with complex medical conditions or chronic medical conditions and co-occurring behavioral health issues was a very, those two populations we thought were very good for focus, and this bill addresses in part some of that. So we definitely believe that the ongoing focus on behavioral health is so important. In terms of bills or policy directions that we did not like, that the subcommittee had before them, we did not support any of the mandatory outpatient treatment legislation that you all have before you this year. And I will say that the association is not opposed writ large to mandatory outpatient treatment, but we oppose all of the MOT bills this year because it was our understanding that there was a group that was looking at those statutes and was going to be prepared next year to have a comprehensive package of changes for those statutes because there are some real fundamental flaws in it. So for example, you have to meet inpatient criteria and not meet it at the same time in order to MOT. And so that's like dividing by zero, you can't do it. So we were hoping for the fundamental issues with that statute to be addressed before we went nipping around the edges with some of the legislation that you all saw before you. We also did not support extending the ECO period to 24 hours. In the comments and
ECO,
the emergency custody order. Yes. So the period of emergency custody right now is at 8 hours. There was legislation to extend that, and really, in the environment that we have now, that's really just extending that period of time where somebody can be in custody to fulfill an administrative thing. It's not about treatment. It's not about engagement. It would just be so that you would have more time to find a bed. Essentially, is how that would shake out. So we didn't believe that in the current environment that it was appropriate to hold somebody for that period of time with no real benefit to the individual who was being held. So there were a few other things that we did not look at, but those are probably the two biggest things that we did not approve of for this year. In terms of the future needs, or what we would be focusing on in the future, 3, I'm gonna give you 5. But I will be quick with them. So in our system right now, I think for the VACSB, obviously continued focus on STEP Virginia, and the funding that needs to be made available in order to execute what we believe is the actual vision of STEP Virginia, which is a baseline level of services and supports in all of our communities in Virginia, which is not meant to be aspirational. It's not meant to fully fund the most amazing system ever. We are trying to even out our system so that where you live doesn't matter, and then we can build on it from there. That, from our perspective, is what STEP Virginia is. So STEP Virginia, the Department of Justice Settlement Agreement, which is on the DD side of the house, but certainly you all saw some DD related bills this year, and that'll be an important focus as well. We have to, I'm sure Commissioner Land is going to talk about that in more detail, or maybe not, because this was kind of a behavioral health focus, but it's certainly going to be something that needs attention over the next year. Obviously, the state hospital census is important. Issues with our Medicaid managed care organizations that the CSBs and other providers are experiencing, that's making it incredibly difficult to serve the people that we need to serve in some instances, and then workforce. Those would be the kind of the 5 that we think, we have absolutely a behavioral health workforce crisis that we need to put some time and attention towards it. Thank you very much. I'm happy to stand here for questions or
Madam Chair?
Yes, Delegate Levine.
So one of the things I learned early in life was when I don't fully understand something, to admit it rather than to pretend to understand and get further lost. So speaking only for me and not for anyone else's ignorance, it would help me if you and actually all the witnesses would explain to me a little bit about your role and your, so I know the community services boards are mostly local, but yet you're head of the state. What is the structure of the group that the agency
Sure.
that you work with, just so I can get there's so many agencies, I'm gonna put them all in the proper puzzle.
Yes, I got it. It is confusing. We are a private nonprofit, and so we don't have the Virginia Association of Community Services Boards doesn't have any authority over our community services boards. All 40 of the CSBs are members of the association, and we really do provide a way for our members to organize, to speak with one voice on issues that are,
So you're like VACO or VML, the public officials join together voluntarily and you represent them?
Yes, sir.
And sort of lobby on their behalf?
Yes, sir.
Got it.
Yes, sir.
That's,
I like to
didn't-
say advocate.
Advocate, that's all good. Thank you, that was my only question.
Any further questions?
You say tomato, we say.
Okay, thank you so much.
All right, thank you.
Deidre Johnson with Vocal.
You could also tell me who Vocal is.
Yes.
Absolutely.
Thank you.
Good morning, Madam Chair and members of the subcommittee. My name is Deidre Johnson, Executive Director at Vocal, which is an acronym for Virginia Organization of Consumers Asserting Leadership. Consumers being those who utilize behavioral health services, which is no longer the language we like to hear. It's those with lived experience or peers. So what we do is recovery education, advocacy, networking. As you guys have seen, we bring some of our stakeholders in that have personal experience with some of the matters that have been before you. Does that answer all of your questions, Delegate Levine?
It does.
Okay. So some of the bills that we have supported for this session is both the barrier crimes legislation as well as the study, because with lived experience comes lived experience. So many times people have mental health challenges and or substance use challenges, and that leads to criminal justice involvement. We also have some workforce challenges for our peer workforce that is a part of our overall behavioral health workforce. And we have peer professionals who are perfectly qualified to be able to go on to continue their education and become clinicians. So we are the lowmen on the totem pole, but we are the most effective part of the behavioral health workforce. I credit my success in life due to peer services that I received before I knew what they were. we do believe that an incremental small step with barrier crimes needs to be made, and that also there is a broader study that needs to be done in the form of SJ 35 that's in session this year. Because I am also a member of the intellectual and developmental disability community, because I am the mother of a child on the autism spectrum. So we've got a unique position in understanding various sides of the legislation. Other bills that we have supported were, initially we spoke against the medical TDO. However, after learning that it was the emergency physicians that brought it, and that was a consensus recommendation from our SB 1488 work group, we supported that legislation, because nobody is more skilled than a physician to make that call as to if someone is in a substance use or behavioral mental health crisis. So extending that time frame for specialized populations, be it medical or those who are intoxicated, makes very perfect sense. Also, we supported, decriminalizing suicide, the SMI death penalty, and some of the bills that we opposed.
SMI.
Serious mental illness.
Thank you.
Sorry. Some of the bills that we opposed out of this committee were the mobile app, because I have a child, as many of our stakeholders do, who have concerns over their children who are either have some sort of developmental disability, a mental health, serious emotional disturbance is what it's called for children. And they can sometimes have maladaptive behaviors in school. And the fear for us is that when a child is going through these crises, it could lead to bullying. I understand that, I understand the intent of the bill. However, if you've got a child such as myself who is a loner and doesn't really have any friends, and they have a meltdown, I don't like that word, but everybody understands what an autism spectrum meltdown looks like for the most part. That child could be videoed, and that could be a confidential video sent in and lead to possible criminal justice involvement for these children. Additionally, we oppose the MOT bills because there was a work group meeting that we were not involved in, and again, nothing about us without us. We would have wanted to have someone with lived experience of forced treatment participating in those in that work group, because there are always unintended consequences. Additional bills that we opposed during the session were the family participation in involuntary commitment, because lots of times what you're looking at with someone in a mental health crisis is they have adverse childhood experiences. So the root of that is trauma. And that can come in the form of trauma through family members. If someone has not specified or removed a family member from their HIPAA forms, then that legislation would have given them every right to know what's happening with the individual. And that's unacceptable, because that can lead to re-traumatization and further exacerbate a mental health crisis. We also did not support the ECO extension of 24 hours, which was SB 1050, because of the blanket extension that would also mean that peers in a mental health crisis would be subject to being held in the hospital for 24 hours rather than getting them into treatment immediately. What happens when someone is in a mental health crisis is that you feel a sense of loss of control, and in order to get out of that crisis, that person needs to feel some empowerment and hope from their situation. Additionally, that particular bill would have kept someone from being able to go to work and potentially losing their job because they have been held for 24 hours, and we feel that's unacceptable. moving forward, our future priorities will continue to be working on the TDO and ECO process. Peer workforce challenges in the form of barrier crimes and the barrier crime study. Continuing to support STEP Virginia and ensuring that peer voices are heard throughout that, as well as the behavioral health redesign and ensuring that peer voices are heard through that process. Additionally, we will be supporting increasing the peer support reimbursement rate and also peer respites. Now, in the state of Virginia, respites is pretty much considered as an IDD service, intellectual and developmental disability service. So this is not the same thing. A peer respite would be somewhere that you go where there are peer specialists, there are no doctors, you get peer support throughout. It's a short-term limited duration that you stay, generally up to 7 days, and you get nothing but peer support while you're there. And peer support is what is the hand that reaches down and pulls you out of the trenches. And those are our priorities. Happy to take any questions if you have any.
Members, are there any questions? Thank you.
Thank you.
And next we have Heidi Dix with the Virginia Department of Behavioral Health and Developmental Services. Oh, or the commissioner herself.
That's even better.
Good morning. My name is Allison Lane. I'm the commissioner for DBHDS, and so glad to be here. Thank you, Delegate Price, for chairing this committee, and for the subcommittee and all the subcommittee members as well for all of your work, and on the full HWI committee. For several years, Virginia's been at work transforming the ability of people with mental health, substance use disorder, and developmental disabilities to easily access high-quality, person-centered, and inclusive services as close to home as possible. That's the key. This is a very challenging process and has had a lot of progress has been made, but it's all been done with a great amount of support from members of the General Assembly. So it's with your help that we're making those strides. Thankfully, the governor has also recognized this tremendous need for additional services, and the budget that he proposed had a lot of demonstrating that commitment that he feels towards this. It included general funds to address the critical needs within the system to improve access to health care and to mental health services, addiction treatment and prevention services, as well as housing assistance. So our main 5 priorities are addressing the high census at the state hospitals, as I'm sure you're aware, continuing the investments in behavioral health, including STEP Virginia, investing in children's mental health initiatives, providing resources that are needed for us to exit the DOJ settlement agreement on time, and then providing for the treatment needs of the sexually violent predator population. Transforming the system, as I said, takes an extraordinary amount of effort, coordination, and partnership, and we appreciate the work this subcommittee has done to advance several of these priorities, including improving the medical TDO, the temporary detention orders. Several people have already mentioned that, as well as conducting a work group regarding our bed registry program. And we've also appreciated the discussions about barrier crimes, our peer workforce, and advancing the dialogue related to supportive decision-making. We're grateful for the General Assembly's partnership, and we appreciate the work of this subcommittee and HWI to advance our goals in these critical areas. And we also would welcome the ability to continue working closely with you, and would like to extend an invitation to get to know your local services, for you to get to know them, and our state hospitals, and more about DBHDS itself after the conclusion of session. So we would love to continue the discussion. Any questions?
Thank you.
Thanks so much.
Thank you.
Will Frank with DMAS? Or
I'm not Will.
and team. And team.
I play Will on television, so I think I can speak for Will. Actually, I'm Tammy Whitlock. I'm one of the deputies at DMAS. I'm the Deputy for Complex Care and Services, and thank you for letting me come and talk to you today. Karen Kimsey sends her regrets that she couldn't be with you today. Virginia Medicaid appreciates that our agency plays a critical role in behavioral health policy and service delivery. and therefore the well-being of Virginia citizens. Medicaid is the largest payer of behavioral health services in the state, and 1/3 of our members have a behavioral health diagnosis. We are committed to ensuring that our members receive high-quality care that meets both physical and behavioral health needs and supports them in participating fully in their lives. In the last year, Medicaid expansion has brought many people into our membership who have not had access to needed behavioral health services for a long time. We know that this access has been critical for their overall health and that it's changing lives for thousands of Virginians. I can tell you that on the arts, the substance use side of the house, about 22,000 members have received substance use services through Medicaid expansion, and we're close to 30,000 on the behavioral health side. So it's getting up there. The governor's proposed budget for behavioral health enhancement includes the implementation of 6 high-quality, high-intensity, and evidence-based services that have demonstrated significant impact and value to people who are at risk of or in need of stepping down from inpatient hospitalization. The enhanced behavioral health services that were included in the governor's budget are assertive community treatment, and if we have questions about this, I have the clinical expertise behind me. Multi-systemic therapy, functional family therapy, partial hospitalization, intensive outpatient programs, and a comprehensive crisis structure to consist of mobile crisis intervention, community-based crisis stabilization, 23-hour observation beds, and residential crisis stabilization units. As the implementation plan stands based on the proposed budget, assertive community treatment, multi-systemic therapy, and functional family therapy might be implemented as early as January of 21, with the other 3 programs following 6 months later in July of 21. Each of these services has undergone a stakeholder-informed study process to establish rates, and this meant hundreds of hours and many people in this room who worked together, including our state agencies, to walk together to improve behavioral health across all of our systems. We are at a unique point in time where there's strong momentum across all of our agencies to assure alignment and support of these interconnected initiatives that aim to improve the quality, effectiveness, and access to care across sources of funding and all doors of referral. DMAS is committed to making a collective impact to reduce the reliance on inpatient hospitalization and to begin the hard work of moving our system towards one that places a strong emphasis on prevention and early intervention for behavioral health conditions. This alignment is critical to our collective success. I think you might have seen some presentations where we've outlined how our behavioral health enhancement aligns with some other initiatives. Behavioral health enhancement seeks to build off the preliminary foundation set by Step Virginia and the community services boards, and to expand similar goals of improving quality and access across the private provider network, which serves the larger proportion of our members in the community. Together, Step VA and behavioral health enhancement aims to meet all of the individuals who need behavioral health services. Both efforts are reinforcing evidence-based practice and designing a comprehensive system of care which produces outcomes. The workforce training funding that was provided in the governor's proposed budget to DBHDS is a critical linchpin in the success of these efforts, as it is intended to develop the workforce necessary to make this lift across our system. It's also important to note that the governor's budget included a 14.7% increase for psychiatric services, which is vital in order to support our licensed workforce. All efforts to develop, attract, incentivize, and support licensed mental health professionals are critical for assuring access to high-quality care. I thank you for letting me come and talk to you today, and we look forward to continuing our partnership with this subcommittee.
And do you have any one-pagers or information about how the oh, yes, I think Sarah's gonna ask that for everybody that spoke, if we could get those. But do you have any analysis on how the funding from the introduced budget was either intact or how it ended up in the House and Senate?
Yes, we have that.
Okay,
I
can
can
you
get
send
that
that
to
to
you.
us?
Absolutely.
And I'll send it out.
Absolutely, Nicole.
I'm sorry, I didn't mean to interrupt you. There's a delightful one-pager that they put together that was presented to the Joint Commission, the Deeds Commission this summer, that lays out Step Virginia behavioral health redesign and how those pieces fit together. It's a couple pages, but I'm happy to share that with the subcommittee. It was very informative and helpful.
We're happy to get that.
Any
for you.
questions?
Madam Chair,
Yes.
it would help me, and maybe I need to see a Venn diagram or something, but to know the interplay between DMAS, DBUDS, and CSBs,
Mhm.
where y'all have separate work, where you overlap, where you all three overlap. And I don't know if that's something you can easily explain to me. If not, it'd be helpful for me to just literally see three bubbles and,
Yeah.
and know where y'all work together, where, nope, that belongs to DMAS, that belongs to DBUDS, because I have a hard time knowing.
Sure. We can certainly provide you with some diagrams, but basically, I will say that DBHDS and DMAS are tied at the hip on the behavioral health.
That's why I'm trying to figure out where you're different.
And so we can draw some things out for you and then include CSBs as well as to how they play.
That
into
would help me
Happy to
understand
send that along.
who we need to talk to when we have a bill about something.
Sure. Anything that's a problem, you can call DBHDS.
Got it.
Does that work?
Thank you.
Triage.
Yes, go ahead.
Yeah, this, and I'm trying to figure out how to phrase this to make it sound like I'm digging something, because it truly is purely just curiosity.
Okay.
But in all the years here, I've not heard the term members before. Is that new relatively? And
It is.
if so, what's the thought process behind the change in nomenclature?
So having been at DMAS a very long time, we have switched, and many people in this room can tell you that, we switched the naming of what we call individuals in Medicaid. Most recently, since 96% of our individuals are in managed care, that's why we call them members.
Okay.
That's generally a term that we use for managed care, but we prefer to use individuals, but it is switched several times. Delegate Ed, you're exactly right. I can't
hadn't
keep
heard
up
that, and
sometimes.
I know there's always a reason why.
Yeah, yes,
So.
yes, exactly.
Thank you.
All right, thank you very much.
Next we have Jennifer Wicker with the Virginia Hospital and Healthcare Association.
Good morning, Madam Chair and members of the subcommittee. I actually have handouts for you all.
All right.
Thank you. So, overachiever, yes I am. Overachiever. Actually, I cheated a little bit because this is information that I provided to the Deeds Commission in the fall of last year when I was trying to explain kind of the role of the hospitals in the behavioral health system. So let me back up. Jennifer Wicker, Virginia Hospital and Healthcare Association. And in my role, I manage behavioral health policy on behalf of our hospital members. And I'm also the liaison to all of our external stakeholders, so do a lot of work with the individuals that are in this room today. I thought it best to kind of level set for everyone, so I'm gonna kind of take a little bit of time to share with you what hospitals kind of have been seeing in the behavioral health system and again, our role. And one thing that comes up continually in the conversations around behavioral health is the state of our state psychiatric facilities, which we all agree they are in crisis and they're continually operating at or above capacity. And there are a lot of things that have gotten us to the place that we are currently, and so I'd like to take a few moments to kind of talk about that. So when we talk about TDOs, we're talking about individuals who have been involuntarily committed. Community hospitals, in 2015, we were admitting 90% of TDOs.
And who was the other 10%? What happened to the other 10%?
The other 10% were being managed by state psychiatric facilities.
Thank you.
As we move forward to 2018, and 2018 is the most recent data that I have available, the number of TDOs at community hospitals admitted went down, and it went down approximately 10%. And that is a result of an increase in the number of voluntary patients that we are seeing. And so a lot of times when we have the conversation about the behavioral health system, there is a skewed focus on the involuntary population. And I think that in order for us to have a true comprehensive conversation about our system and the best way to address the needs of the entire system, we need to include not only the TDOs, but also the voluntary population. And so there actually is a slide on page 2 that you have, slide number 4. It's difficult to read, but it kind of shows you how many patients community hospitals are admitting as compared to our state psychiatric facilities. So you will see that community hospitals still manage a bulk of the patients that are in need of inpatient care. So, with that information as kind of the context as the information that I want to provide to you all, I'd like to say that the investments that are included in the budgets that I presented, whether it's the governor's budget, Senate, or House, there are a lot of things that we support. And specifically, I'd like to speak about the fact that Virginia's behavioral health system right now is set up to really focus on individuals when they're in crisis. And that is a huge disadvantage that we have in our system. So some of the things that have been brought up by my colleague Jennifer Faison as it relates to STEP Virginia, that is an opportunity for community services boards to provide more care in an outpatient setting, and that's something that that VHHA strongly supports, and we hope that there will be enough funding within that initiative to ensure that CSBs are able to do the work that they need to do. DMAS and DBHDS spoke to what is envisioned with behavioral health enhancement, and that initiative would also increase the amount of services that are available outside of the inpatient setting. So on the front end as well as the back end outpatient services. And that's something, again, that VHHA supports. But as we move forward with that initiative, we want to make sure that we are cognizant of the cost that it takes to actually provide various levels of care. And as currently proposed, one service or two services that the hospitals are very interested in providing is partial hospitalization and intensive outpatient services. Now, those are outpatient services that can be provided to individuals either as a step down once they've been inpatient and they're ready for discharge but not necessarily ready to be on their own, and can also be used as something to divert individuals from being admitted in the first place. And we're very concerned with the rate of reimbursement that is imagined currently, and so we hope that in continued conversations we will be able to get to a place where the service is reimbursed in a way that's reasonable as well as sustainable for our hospitals to participate. And one of, yes, sir.
I sorry to interrupt you, but it's easier when
Delegate
you're in the
Levine.
flow.
That's
Who reimburses you? Is it insurance? Is it the state? Is it Medicaid? Is it all of the above?
all of the above.
And so when you say reimbursement rate, you're talking about
The
all of
Medicaid,
those?
we're talking about on the Medicaid side. So
Okay.
the behavioral health enhancement is focused on the Medicaid population. So
Thank
that's
you.
what we're talking about. So some of our hospitals currently provide PHP and IOP, and there's a commercial reimbursement that is enough for them to be able to provide the service. But as I mentioned, the rate that's proposed by enhancement is a lot lower than that. So talked about the outpatient piece, and the other thing that is a huge barrier for our hospitals is workforce. So there's a lot of conversation around the whether or not we have the right number of inpatient beds available in the system. The hospitals would say that we do, but what one of the issues is that we have hospitals, and there's a slide in there that kind of speaks to this, and let me direct you to it. It would be page 3, slide number 8, where it talks about the number of inpatient psychiatric beds that community hospitals have within the system, and it's around 1,800. But out of 43 facilities that provide inpatient psychiatric care, only 6 of them are operating at their full license capability. So there are some beds that are licensed but not operated, and the reason for that is because of workforce. So behavioral health workforce shortages is a huge issue for us. So happy to see that there is some language in the budget around that particular issue. And then I would,
Madam Chair.
yes, sir.
Madam Chair,
Yes.
so that's, on that issue, is that a training issue or a compensation issue or both?
Well, it's, and bodies available, as well. There aren't enough individuals, within Virginia, especially around child and adolescent psychiatry, adult psychiatry as well. So there are certain levels of work that we are struggling to be able to find the folks that come in to be able to open up more additional beds within the system.
So it's a spectrum thing, it's the doctors as well as just
Nurses and
nurses,
techs,
yeah.
it's all across the line, but you will find that a lot of the conversation is around the psychiatrists and the inability to be able to bring psychiatrists within the system. So to address your homework, in reference to legislation or policy priorities that we supported, they've already been mentioned. We supported the extension of the TDO under certain conditions. So the medical TDO, if an individual is determined to need more care in the medical space or is intoxicated, allowing them more time within the hospital before making a determination of whether or not they should be involuntary committed. We completely support that. But on the flip side, as has already been mentioned, extending the ECO period from 8 hours to 24 hours as a blanket extension is something that the hospitals are extremely concerned about. And within the legislation, you all actually didn't see it on this side, it was introduced on the Senate side. Not only was the ECO period extended to 24 hours, it also transferred custody of those individuals from our law enforcement officers to hospitals. So that is a whole different role that our hospitals would have had to have taken on, which would have been extremely costly for our membership. And also, that's not really the role of the hospital. We're there to take care of the individuals and make sure that they get to where they need to get to and not necessarily provide custody to them. So that is something that we were extremely concerned about, but that fortunately was carried over to next year. And then I would like to provide kudos to our partners at DVHDS. Last session, there was a work group that was established through Senate Bill 1488, which Hanger introduced. And basically that work group was brought together to discuss issues around TDOs, barriers and those types of things, and what we could do to address the state census at our state psychiatric facilities. And that was a great opportunity for stakeholders to be at the table and to have a conversation about all the issues. And there were a lot of opportunities in which there was consensus. And so I think that, in the off session, there are a couple of work groups that have been put together. We will have the opportunity to do that again. And I think that, as has already been said, we all need to be at the table when we're having these conversations, because unfortunately there are a lot of assumptions and a lot of perspectives that may not be true that are kind of brought into the policy conversation. And once you've had an opportunity to really talk with everyone, you find out that there is a lot more that we're in agreement with than we disagree about. And so continuing that process of the work groups and actually providing recommendations and implementing those recommendations as we have during this 2020 session, I think is a great way to go. And thank you so much for the opportunity to speak, and I'm happy to answer any other questions that you all may have.
I do have, when you were talking about the outpatient treatment that could be used as step downs or diversion from admission, you said partial hospitalization. What was the second one?
Intensive outpatient
Thank you.
programs. You're welcome.
Any other questions? Yes.
Just statistically, if someone's involved in a TDO, is it measurable? Do we see repeat occurrences of the same person? How much of it is individuals? Because you're dealing with roughly 54,000 in a given year.
Yes.
That you're having. Do you have any?
I don't
numbers
have
on
any
that?
numbers about readmissions, but I hear like my hospitals in my head, and I'm sure that they would say that there's a high number of individuals that consistently cycle back in to the system that we are seeing. But I don't have an exact number. But to the point that you were bringing up, As I was preparing for this presentation, one thing that, for the Dee's presentation that I made last fall, one thing that I was interested in was in understanding the number of emergency evaluations that were being done. And on page 2, slide 5, there's some information that tells you that in fiscal year 2015, there were about 83,000 emergency evaluations that were conducted. And out of that, about 29% of those became TDOs. If you fast forward to fiscal year 2018, that number increased significantly, and instead of 83,000, there were 91,000, almost 92,000 emergency evaluations that were being conducted, and still 28% of those were TDOs. But what that shows you is that the need is significantly increasing. There are more people that are in crisis and seeking behavioral health care. And that's something that we need to be aware of within the system. And again, some of the initiatives that have been mentioned, Step Virginia and behavioral health enhancement, I keep wanting to say redesign, enhancement will, kind of speaks to addressing the issues prior to people actually needing an inpatient bed. And one thing, I'm sorry, I don't mean to trespass on your time, but one thing that's also important is that the needs of patients are changing. So there are a lot of individuals who present with a lot more medical complexities. They are a lot more aggressive, for lack of a better word. We have a higher need for IDDD, programming and things of that nature. And within the Senate budget, there is actually funding that has been provided for community hospitals to develop pilot programs, focus on some of these targeted populations that our state psychiatric facilities really aren't equipped to handle, and community hospitals want to figure out a way to address. So we're hoping that will stay within the budget, and it will give us an opportunity to address some of those populations that really should not be going to the state psychiatric facilities.
Madam Chair?
Yes.
I'd like to follow up to Delegate Head's question. It would really help me get a handle around this if I knew out of the emergency evaluation community population or the TDO population, what percentage are first timers? What percentage have been there once before? What percentage have been there, 5, 10 times before? What percentage have done inpatients? What percentage are coming from their inpatient to their emergency or haven't done inpatient for a while? Just to get an idea of when people are in crisis, is it their first time presenting? Are they multi-timers? Are they in inpatient? Are they not? So that we can, at least for me, can get a handle on what kind of people we're dealing with. 80% are, multi-timers who have had inpatient care, then maybe our inpatient isn't, our outpatient isn't working. Just those kinds of statistics, and I don't even know if anyone has them, but that would be really useful for me.
So you will be pleased to know that there is a work group that's going to be looking at the type of data that we need to be collecting to understand some of those questions. So post-session, I'm
Great.
sure that Commissioner Land will have her team putting together a group of folks to kind of look at that and to get to some of those questions.
Fantastic, thank you.
And
Go ahead.
as just thinking in terms of when you're managing anything, data mining is a wonderful thing. There's got to be some consistent
Yes.
platform
That's right.
for everybody. And the biggest problem that we have is we don't even have a consistent platform inside state agencies, much less outside in community hospitals. And we've got so much stuff. We've got to find some program out there to get the data consistent so we can really analyze it, because you can't have improvement without good data. We just can't. And I
Don't disagree.
yeah, would really like to see us move that direction.
Thank you.
You're welcome.
Thank you.
All right, thank you.
What gets measured gets managed.
Okay.
I have no idea. 20% first timers? Are they someone who's these people that just go and get outpatient care? It's just family.
Okay, so we have. So if we do 5 minutes apiece, we have time for 3 more speakers. And so if we can find a democratic way to talk amongst ourselves to see who those 3 will be.
I see 3 people standing, so.
Yeah, just wanna make sure.
That works for me.
No Hunger Games challenges out there for it.
Hi, good morning. I'm Colleen Miller from the Disability Law Center of Virginia. Let me give you some cards here because we are a statewide advocacy organization. We represent people with disabilities, which includes your constituents. And so if you've got a constituent who calls you about a disability rights issue, could be special ed, Medicaid, abuse and neglect, anything like that, please don't hesitate to call us. We can't represent everybody who calls us, but we do try to provide some sort of help to anybody who calls us. We are a creature of federal law. We were created by a number of different federal statutes, but our mandate is to serve people with disabilities in Virginia, primarily to investigate abuse and neglect, but also to protect legal rights. I wanted to thank the legislature this year for the great work you did on the barrier crimes legislation. And also for committing to a study on the psychiatric bed registry. We don't think that that is functioning the way that it was originally designed to function. Not sure that it can, but it is absolutely worthy of a further study, and grateful that that's going to happen. There's 3 substantive issues that I'm hoping to talk to you a little bit about. One is supported decision making, and you haven't really heard from anybody today about that. You've heard a lot about the mandatory outpatient treatment concerns, and we've got concerns about that as well. And the third thing that I wanted to address, and it was basically Jennifer who reminded me of this, is to talk about the conditions of our state psychiatric hospitals. You've heard that they are crowded, they are at capacity. You may not have heard that there's more than 200 people who are in the state hospitals who do not need to be there. The state's treatment professionals have said these people are ready to go, and they are stuck there, some of them for months at a time after they've been declared ready for discharge. And that's because we, as a state, have not adequately funded enough resources in the community for them. So there's stuff in the budget for better funding for permanent supportive housing, and that's going to go a long way to address that. The issues are much more complicated than just providing supportive housing. A large percentage of the people who are in state hospitals who don't need to be there got there by virtue of a finding them not guilty by reason of insanity. And the courts are sometimes reluctant to allow somebody to leave the hospitals even though they no longer need to be there. So it's a complicated problem. But there are, at least as of the end of December, 217 people in the state hospitals who don't need to be there. So I think that's got to be a top priority. Another thing that we are hoping we can spend some time thinking about in the state hospitals is that in 2014, you all passed some legislation to make the hospitals the location of last resort. If somebody's in crisis and they can't find a bed anywhere else, the state hospitals will accept them. And since the time of that legislation, we have been tracking a steady increase in the number of people who have died in the state hospitals shortly after admission. We don't know what that increase is, but it's been a dramatic increase every single year, higher numbers. We think that what's happening is that our state hospitals are being forced to take people by virtue of the last resort legislation, being forced to take people that they are not equipped to take, people who have serious medical conditions. And our state hospitals are psychiatric hospitals. They are not medical hospitals. So we think that I mean, it just falls too closely in line with the last resort legislation. So we're hoping that we can spend some time looking at that and seeing if there's something that needs to be changed in that. We've asked the department to really investigate those deaths and find out if there is a hospital that is dumping them, a nursing home that is dumping them, if there's somebody, 1 or 2 locations that are the prime source of these admissions that probably did not need to be there. And that's just by tracking deaths. We also have tracked other medical incidents that happened shortly after admission that kind of enhances our suspicion around that. So those are the things I want to say about the hospitals. can I move on to supported decision-making, or am I overshooting my
You got
time?
12 seconds.
Okay, 12 seconds. Supported decision-making, my question to you is, what do you all need to understand this better? It is coming, many states have adopted it. It's a great way of avoiding as you know, the restrictions of guardianship.
I love supported decision.
Yeah.
I have no problem with it.
But it kind of like blows people's minds. I mean, the proposals that you had this year were for a really highly structured, forms and requirements and stuff like that. And that's not the way supported decision making is supposed to work. It is supposed to work on the assumption that everybody has capacity. And so we work from whatever capacity you have, whatever capacity I have, and build the supports around that to strengthen that. And instead, the proposals that you got this year were much more towards like pseudo guardianship. And that's really not what supported decision making is. So what do you need? What can we help you with? Would you like to know how other states have dealt with it? Would you like to hear from our clients who have done something similar to it? Basically, enhanced powers of attorney is the way that we approach it with our clients. So yes, I'd be happy to pull together information on how other
So
states are
I
addressing
do
this.
believe that we will have a platform in the interim in order to talk about this specific topic, and so we'll definitely be in touch and get you the
Excellent.
things that we need so that once we do come back together, you all can have that for us.
Excellent. Okay. All right. So thank you.
Okay, and next up?
Hi, I'm Jennifer Spangler. Thank you, Chairwoman and members for letting me speak today. I am an individual who has experienced mandatory treatment, emergency custody orders, TDOs. So the big picture for me is that people who have an illness and is forced into treatment, it's not helpful, and for me it's harmful. It doesn't teach me anything about how to manage my illness. All it teaches me is how to survive hospitalization and the treatment. In order to be discharged, I have to participate and comply regardless of my treatment and how it affects me. My treatment placement is never my choice. I have tried to get my husband to speak for me. It doesn't work. They just do whatever they think is best. Also, it's not that I don't want help. I always want help. I don't want to live in crisis. It's bad for me. It's bad for my close relationships. But I just think the help that I get is harmful. And that's the problem. And for me, I always go back. But a lot of people are afraid and they avoid at all costs. And the other thing, as far as extending, treatment, one of the bills was to extend to 90 days. If you have a poor treatment plan, that's 90 days of a bad treatment plan, which is going to require many, many more services to get well. And also, you could lose employment and therefore not have the funding or the transportation to get to your job. And so, briefly, I'm just going to share with you a personal experience. I have many. This is just one. I entered an emergency room in crisis. I was still I escalated while I was in the emergency room. I came in with some faculties. Anyway, they separated myself from my husband, and I was forced to sign a document which I was in no capacity to sign. I was left alone in an environment that was scary. There's lots of noises and rushing, and there was nobody to speak for me. I'm disorganized in thought, and people there, they want to rush. They don't want to wait and try and help me describe things. I was told a treatment that was bad for me. I was also working towards pregnancy under the direction of my OB and my outpatient psychiatrist. The treatment that they told me was bad. I had bad previous experience. And also, these drugs that they inject into you, they kill children. So, there I am just trying to get better, and, this is the place that it put me in. So I was pinned between a police officer, a staff, and I was injected with this. And the question I asked them was, okay, well, if I fight you on this, you're going to give it to me anyway. They would. I've had the bruises and everything to go with that. And so they gave me the treatment, and I laid on a cold table in the emergency room for I don't know how long, just convulsing and sitting there. Eventually, my jaws and muscles locked up, and they had to get me somewhere where I could be treated for that. They pried open my mouth, forced treatment into me, another drug that does bad things to me. So I was no longer locked jawed, but I was hallucinating. I don't take drugs. That was my first experience. It was very strange, but I knew it would wear off because I knew it was a result of the drug that they gave me. And so I had that horrible experience, and I had to go to groups, and I had to take the treatment that they had in order to get discharged. That's the way it goes. And so upon my discharge, I'm sure you can imagine, after being forced through that, I needed continual services. So maybe I go home and I'm still traumatized and something else happens. Then of course I need to be re-hospitalized because I had come out of the acute state of problems and tried to go back into my life, but I need further services because of what happened to me. And so situations like this, over and over and over again. I manage my illness well. I've had 10 situations over 20 years where life basically exceeded my medication. So you can imagine the problems of the system when you're forcing people. It's very expensive to be hospitalized, 24 grand like that in 1 year for 2 hospitalizations. So I really hope that you will involve more people with my experience because it's important, and community services need to be the priority. Thank you.
Thank you.
Good morning, Madam Chair, members of the subcommittee. My name is Amy Parent-Seibert, and I'm here on behalf of the Virginia College of Emergency Physicians. I won't take up too much of your time today because I think a lot of the folks before talked about a lot of things that we've been collaborating with. So we've been partnering with the Department of Behavioral Health, DMAS, the hospitals, consumers, as well as the community services boards to work on all the issues that they talked about today. We were supportive of the bill that expanded the medical TDOs to intoxication. We felt like that was a way that the hospital emergency departments could help with the issues and the census issues that we're having in the state hospitals, to do a way where we could actually look at somebody from a medical standpoint and be able to hold them from a medical standpoint as opposed to just the psychiatric piece. We don't support the 24-hour ECO extension. I think actually the woman before me sort of gives a good reason as to why we don't think people should be in an emergency department for any longer than 8 hours. Honestly, we know that's not the right place for people. It is a place that can be put people into further crisis. We want to be able to get them to the right form of treatment as fast as we can, and that's something we want. So we really worry about extending it to 24 hours in the ER because we still think that's the right place for patients. We want to do our best to get them to the care that they need as quickly as possible. A lot of the things I think that we're looking at in the future, continued collaboration. I know there's a work study group that's going to look at who's able to do the TDO evaluations. Right now it's just the community services boards. We've talked in the past about ways that maybe the emergency department physicians could help with that process. Not necessarily take the whole thing over, but if there's a way that we can sort of help and work in collaboration with the CSBs and the folks there to be able to do a better job to be able to extend that workforce issues that we know that we have. And again, getting patients into care faster as opposed to keeping them in the ER longer. So we appreciate that study and look forward to being a part of that. We do think there is a clear issue of patients who have comorbidities, which are a lot of severe medical issues along with psychiatric issues. And I think it's true that the state hospitals don't have the capacity to take care of those folks. I know Jennifer Wicker mentioned incentives and stuff for hospitals to be able to take care of those patients, and we support that. We know that people with severe medical issues who still are having a psychiatric crisis need appropriate care. So we look forward to kind of continuing again to have those conversations. One of the biggest issues that we have with the emergency physicians is communication and collaboration with inpatient facilities, whether private or public. My doctors always struggle because it's really the only time they have to transfer a patient when they don't always speak to the physician in charge. Any other time, if you have a cardio issue in the ER or you have a brain issue, you always talk directly to a neurologist, you talk directly to a cardiologist about getting someone somewhere, and that's not the case. We can get communication with the psychiatrist if we ask, but it's not how the process typically works. And I think sometimes it's a bit of a struggle from a medical to psych standpoint. So that communication, I think, is important. We've been working with the department as well as the hospitals on guidance and guidelines for how best to get people the assessment pieces and what tests are needed and what aren't needed so that we can do a better job. We've got some good guidelines. I think we need to expand on that and keep working in that area. And I think the other thing I would say is finally, I think it would be really helpful if we keep focusing on ways to keep people out of the emergency department, mobile crisis units, and be able to roll those things out in a really sort of a uniform way across the state. So I think when we do it kind of piecemeal, I think it makes it much harder. you know, I think it's great that we have good programs in a lot of different places, but it'd be nice if we could have, like, do something really well, like do mobile crisis units across the state very well, or do CTACs across the whole state really well. And so I think that's something we need to kind of focus on, because I think when we have pockets of that, it helps, but the uniformity is difficult, I think, for patients, as well as for physicians, as well as the care that's received. So I think helping to continue to invest in ways to help keep people out of the ER is important. One of the things, last thing I'll say, Delegate Head, we actually do have a program in Virginia called the Emergency Department Care Coordination Program that we started in 2017. It's actually a software system that sits on top of everybody's EHR, so it actually connects all the emergency departments in the state. We've been working with the MCOs as well as the insurance companies and all the different departments to start identifying super utilizers, so folks who come to the ER 6 times or more. Mental health patients are certainly part of that. We need to continue to be able to fund that program, because I think what we can do is we can start identifying, and what they do is have care coordination plans in there, so folks who are coming in, we'd be able to identify who's their mental health provider, who's their family doctor, who should they be going to see so that they're not coming back to the ER. So it helps provide our physicians with tools to know who they're supposed to be seeing instead, and helping to directly connect them. One of the phase 2s of that project is connecting the community services boards as well as family physician practices, so there is that direct real-time interaction between when a patient's in the ER, those folks would know that their patient is there. So I think those are some ways that we talked about when we have that sort of data collection, and there is actually something that does talk to everybody. So I think that could be helpful, at least from the emergency department standpoint, when you're looking at folks that are coming in. So that's it. But thank you for your time. We appreciate it.
Thank you. Awesome. With 20 seconds to spare. Well, we want to thank you for your time and your input, and we are going to get with Delegate Chairman Sickles to know what the specific work groups will be over this interim, and then also knowing that there'll be some things that we'll be working on next session as well. Please feel free to reach out to us with the information that you all gave today, or if there are other things that develop in the interim, please feel free to communicate with us. And with that, we stand adjourned.